Wonderful. Hi, everyone. Thank you for
Hello,
joining.
go ahead.
Oh, sorry. You remind to mute yourself. That would be appreciated. Thank you. Hi, everyone. Thank you for joining us today for our preoperative testing work group. My name is Christy Degner, and I'm a site engagement coordinator for MVC. I look forward to facilitating this work group for you today. So today's preoperative testing work group will feature a presentation by Tony Cuttitta of the Michigan Program on Value Enhancement, otherwise known as MPrOVE. As the program manager for the Michigan Program on Value Enhancement, Tony brings over 15 years experience as a health and healthcare researcher and quality improvement expert. He leads the MPrOVE team, who conducts quality improvement and research activities focused on improving appropriateness, de-implementing the utilization of low-value services, and generally right-sizing care to provide patients with the care they need, but not more. Much of MPrOVE's recent work has focused on the emergency department and preoperative space, tailoring the amount and site of care to the needs of each patient. Thank you, Tony, for being here today. Before you begin your presentation, I do have some brief housekeeping items to review. First, this session is being recorded. The slides and the recording will be shared with the attendees following the work group. Secondly, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We also will have some designated time at the end of Tony's presentation for a Q&A. And lastly, your feedback is important to us. If you could please complete the post-work group survey in a link that will be provided in the chat at the end of the work group, as well in an email sent following the work group, that would be greatly appreciated. With that, you are welcome to share your presentation, Tony. Thanks for being here.
Great. Thanks so much, Christy. As I get set up here, just to kind of reiterate some of those points, that any comments or questions are welcome in the chat, or even if you want to raise your hand. I think we have quite a bit of time today, and I don't plan to talk the whole time, so we can certainly kind of stop and address any items as we go forward here, or spend some time with Q&A at the end. So thanks for the introduction. Happy to be here. I'm going to start with a very brief kind of high-level introduction to MPrOVE, and then really get into kind of our pathway for addressing low-value testing before low-risk surgeries. So like I mentioned, really high-level look at MPrOVE. So really focusing on quality improvement, really with a data-driven and research lens. You don't need to kind of understand this in great detail, but I think the three columns here are helpful. So maximizing value, whether that's right-sizing the care on the patient side or just efficiently using resources, whether that's hospital beds or clinician staff time. Most of what we're going to talk about today, reducing unnecessary care, so taking away things that are not providing value, and then also improving outcomes, improving things like patient satisfaction. And here's just kind of a visual way of talking through some of the things that Christy mentioned that are in my background of experience and that MPrOVE does. So trying to promote appropriateness, trying to promote care at optimal care settings, whether that's in the hospital, in outpatient settings, at home, or through virtual care, and de-implementing low-value care and wasteful processes. I think all three of those are going to be related to the talk today. And just to think about it again in kind of a fun, more childlike way, right? Just kind of thinking about it from the Goldilocks principle, right? So we're trying to strike that balance of being right in the middle here. So too much care is over-treatment. We do eventually get to harm through overuse because we are exposing patients to additional care, tests, or treatment that they don't need. And by definition, that's always introducing harm. There's a key component of patient burden. So every type of care or test that we ask a patient to undergo is effort and burden on their end. And if that's valuable, then that burden is worth it. But if the test or procedure that we're asking them to go through is not valuable, then we're just adding unnecessary patient burden. And then obviously the use of resources that I mentioned in the slide prior. So that's what too much care looks like, right? Then on the other side is not enough treatment, which causes other types of problems, right? Lack of access, poor quality, harm due to lack of care, obviously safety events. So that's also not where we want to be. We want to be right here in this appropriateness, this just right space. So patients are getting the care that they do need, but not more. And again, I think this relates a lot to really trying to right size preoperative testing that we'll be talking about today. Again, just kind of one more wrap-up slide on the value of right-sizing care, opportunities to increase efficiency, opportunities to reduce clinician effort because they're not performing tests and treatments that are not necessary, reducing the patient burden that I talked about, and also potentials for reducing patient harm. So there's kind of a really brief high-level background on MPrOVE and the work that we're trying to do at Michigan Medicine. If anyone has any questions, feel free. I'll go ahead and kind of get into the topic of the day here. So just a little bit of background, and hopefully this information isn't new to all of you, but if it is new to you, that's totally fine too. Really just noting that the background for the existence of low value testing is pretty well established. Preoperative testing rates before low risk surgeries range anywhere from 8 to 85% of common tests and procedures across the state of Michigan. So while we can't say for certain that 8% is right, I think we can say that amount of variation is not really right sized, and there's all different types of providers doing all different types of things. And again, getting into the right sizing concepts, this routine preoperative testing and this high variability remains high, even though it's specifically not recommended by several academic societies. It can be associated with things like surgical delays and wasteful spending. And again, it adds to that patient burden of unnecessary stress, whether it's having to go to it or even potentially delaying surgery down the road. So now we'll get into a little bit of MPrOVE's role over the last number of years really in this space, and you'll see kind of a lot of it partnered with MVC. And this is just one snapshot of a look. We could share a lot more. There was also a paper written on this, but this really just highlights that kind of 8 to 85% number. So this is looking at preoperative EKG rates before these low risk procedures, 3 low risk procedures: lumpectomy, cholecystectomy, and hernia. And the plots here are just those procedures across MVC hospitals in the state of Michigan. Again, you just see this huge range of variability. And really what we're trying to do is get closer towards right sizing those tests for patients who need them, but not for patients who don't. Does someone have a question? Okay, no worries. I'll forge ahead here. So, getting into, again, MPrOVE's been in this space really over the past 4 years or so, and done so with a lot of partnerships with MVC. So kind of the 2020 piece is what I just talked about, and really that acknowledgement of that high variability in testing rates. EKG is what's shown here, but there's a lot of variability shown in other preoperative test labs and things like that as well. In 2021, and this was really primarily MVC, they obviously put together the preoperative testing report that is now available, which is an excellent resource to really show where your hospital or health system might be compared to peers across the state of Michigan, and that kind of is continuing on now. In 2022, MPrOVE did a lot of local work at Michigan Medicine to better understand drivers and reasons behind preoperative testing, and I'll get into that a little bit more as we go through the slides here. And then in 2022, also a lot of continued conversations with MVC as well as MSQC, Michigan Surgical Quality Collaborative, around potential intervention opportunities, which led into this year, 2023, where both MVC and MSQC have statewide P4P efforts and value-based metric efforts that essentially incentivize, reducing low-value testing. So really, I think the main takeaway, like I started with this slide, is that there's been a lot of good partnerships with MPrOVE, MVC, as well as MSQC, and those connections have really been great in terms of gaining knowledge about preoperative testing and really kind of further developing interventions that have a chance to improve, and again, really related to common preoperative tests that can be low value or unnecessary, related to these three target low risk surgeries here. Again, lumpectomy, hernia repair, and cholecystectomy. I will pause there for any questions on kind of this background information or any of the collaborations across MPrOVE, MVC, and MSQC. Any questions or comments from folks? I don't see any, but we can certainly kind of get into that as we go. So now I'd like to get into a little bit more of the specifics of the talk here. So talking about how MPrOVE's approach has been applied to de-implementing low-value preoperative testing, and just a little bit more of the specifics. And how we're going to go through this today is kind of a bit of a roadmap approach in terms of how we went about this. Obviously, for those listening, like, you don't necessarily have to follow this this roadmap or this plan specifically, but it just gives you a sense for some of the work we've done. And then also think about, obviously the work that we've done can be shared and leveraged at other local sites. So that's what I'll talk through today. Again, welcome kind of questions and comments along the way. So, where do we get started if the goal is, over the medium term here, long term, achieving reductions in low value testing and getting closer towards appropriateness? And this will kind of flow out here in terms of the process that we went through, review available baseline data, find a champion, really do a lot of stakeholder engagement and local discussions to gather more information and data about understanding the problem, and then moving into developing resources, decision aids, specific strategies that we felt would address some of the issues that our stakeholders raised. And then once you have those in place and available, kicking off an engagement and hopefully getting to the point where you're reducing low value testing, you're maintaining stakeholder engagement, and then you're monitoring the impact over time. So this is kind of the roadmap that I'm going to walk through over the next 20 minutes or so. And we'll go through kind of each of these steps, and then we'll bring this up again at the end as a further reference point. So to start with reviewing available baseline data, just looking at some things that we've learned, and again, this actually goes back a little bit in time here. But one of the key things is that clinician values around preoperative testing are remarkably consistent. So even though we see variable use and ordering of tests that I talked about earlier, like the values that clinicians describe as why they're ordering tests and why they think the preoperative process is important are largely the same. And it's what's at the bottom here, which is that safety and evidence-based medicine are both shared values. So they're being ordered out of the perception that they improve safety, and out of the perception that ordering the test is a form of evidence-based medicine. Now, there's a little bit of conflict here because, again, some of the evidence base really suggests to them, but the perception may be that ordering them adds safety. But that's okay. I think, again, the important thing to remember is that if we're able to get clinicians and a strong evidence base that shows that a certain appropriate amount of testing can improve safety, that they're going to kind of follow that lead. And also just to acknowledge, as we're going through here, there's no, in any way, no perception that any providers are over ordering tests for any reason other than out of concern for the safety of their patients. So also important to remember that as we go. But then, like I had mentioned in kind of the background materials, is really that preoperative test ordering practices are remarkably inconsistent. So even though the values of evidence-based medicine and safety are there, how things are actually ordered are inconsistent. And we learned a little bit about this in 2022 as we did some interviews in ethnography, which is basically just observational work about how the processes of ordering tests happen. And really, I'll turn your attention to the 3 bullets at the lower right here. A big thing that there's perceived differences in clinician perspectives, and you can kind of see described there. So at least at Michigan Medicine, there's kind of 3 stakeholders who can order a test or want a test to be done for a certain type of patient: anesthesia, pre-op clinic, and the surgery. And what we found is that those 3 groups didn't necessarily fully understand what the other groups wanted, and that could drive, that could certainly drive preoperative testing. And then also the top bullet there, just that oftentimes the same surgeons performing the same procedure on the same type of patients order kind of vastly different amounts or rates of tests. And so the next slide kind of gets at this perceived differences in perceptions of who wants the test. So when you actually got down and talked to people, and we think about, oh, we're ordering all these preoperative EKGs before hernia patients, why are we ordering that? And so, the surgeon might say, well, I think the pre-op clinic ordered it, so they must want it. And the pre-op clinic might say, well, I think anesthesia wants it, but I'm not sure. But if I ask them a question, I'm not going to get an answer for a few days, or I might kind of get in trouble. So I'm just going to order it and kind of play it safe. But then when you talk to anesthesia, they say, yeah, I don't need to see an EKG for this, 32-year-old patient with no history of cardiac issues. So really kind of bringing these perspectives together so that all of these 3 groups who might be ordering tests actually have a base understanding and agreement of what the other stakeholders might want. And moving on from kind of reviewing baseline data, next is finding a champion, so identifying interest in local stakeholders. And this relates a little bit to the prior slide, right? But here at Michigan Medicine, we have the division chiefs for minimally invasive surgery, which conducts hernias and choles, and then surgical oncology, Leslie Dossett, who conducts lumpectomies, and then also engaged anesthesia in this process, so that they can be part of kind of the development of this and behind any attempts to change preoperative testing practices. And again, so I think this is another kind of key step in the process, right? Is finding some champions who are interested and who are willing to kind of not just maybe change the behavior themselves, but also spread some knowledge out to other key stakeholders. Discussing the topic with stakeholders, again, gets at that issue of coordination and kind of common language and common understanding of what people want. So a lot of the work that we ended up doing kind of in this stakeholder space was socializing concept, learning about the perspectives of these different groups, and kind of getting ideas on what would be needed to actually impact test ordering practices. So again, kind of this really social aspect. And then moving on from kind of discussing the topic with key stakeholders to gathering more data, but the two are related, is that really what we heard from our champions, if I could just go back one slide here, from our surgical champions, was that their colleagues would really like to see testing rates and really better understand the evidence base, again, getting back to those values. And that would be a good driver of behavior change. So when we get into gather more focused data, and again, I think this is like a general concept that needs to be responsive to kind of your local champions or what your local stakeholders are asking for. But this is what we heard from ours, was that more data, more information on testing rates and what was a high value test versus a low value test is what they asked for. So that's how we kind of led to this approach. So with the help of numerous wonderful medical students and a little bit of organizing by the MPrOVE team, we worked to do a medical chart review for 100 cases for each of the 3 target procedures. It's kind of described there on the left, 300 total cases, again, 100 for hernia, 100 for chole, 100 for lumpectomy, and really just try to assess the risk of the patient and whether or not the test being ordered really aligned with evidence-based guidelines, society recommendations, if there were clinical indicators that actually suggested that a test could be informative towards the risk of the patient or not. And I'll just go through, this is just 2 slides here. The first one is on kind of surgical oncology lumpectomy. So you can actually see that when we looked at 100 cases, 50, about half of CBCs, BMP, CMPs, and EKGs were not necessary, not indicated, not in line with existing guidelines. So obviously room for improvement there if about half of those being ordered are not necessary. But the slightly better news was that only about 19%, so about 1 in 5 patients actually received an unnecessary test. So about 4 out of 5 patients undergoing a lumpectomy did only receive tests that were of high value in terms of preparing them for surgery. So room for opportunity here, but not looking too bad. And then when we moved into minimally invasive surgery, we saw higher rates of unnecessary or non-indicated tests for these 3 preoperative tests. And the rate of patients who received at least 1 unnecessary test was greatly increased in this group, so 45%. So again, I think this was informative so that the champions could understand and eventually, and I'll get into this a little bit, but eventually share this with their surgeon teams to better understand the rate of tests that were being ordered, as well as, how many of those tests were actually high value versus low value. And then one other piece to mention here, which again aligns with the background data, is just to show that testing practices are really inconsistent between providers. And again, this is testing rates all when they're all performing the exact same surgery. So this is another piece of information that tells us that there were certain surgeons that were really testing a lot, and they were probably the best kind of opportunity to intervene on. And so all that kind of baseline data, finding a champion, discussing the topic with stakeholders, and gathering more focused data, all of that information really led us to developing resources and strategies that could be used, to really change behavior around this preoperative testing. So we developed a number of resources, which are kind of summarized here, and I'll get into the specifics, which I think are easier to understand. I think the primary tool was a very simple workflow, which you can see on the screen here, which attempted to assess patient risk defined by ASA class, and really determine if the patient is low risk, which is defined by ASA class 1 or 2. That's how we did it at Michigan Medicine. You could certainly define risk class in a number of different ways. And I think like the specific method is less important than the fact that you're really trying to assess risk and clinical indication. But really you can see here, low risk patients for these 3 target procedures. If the patient is ASA class 1 or 2, lower risk, yes, really that no preoperative testing at all is really indicated for these procedures. And then if the patient is not low risk, meaning they're ASA class 3 or above, then there's some other things to consider. Stability of the symptoms, is the disease asymptomatic? If there's a lot of stability and no other issues popping up, there's still probably no preoperative testing indicated. There's a little more background information we provided here. But then if there's still risk, to also say that there is a certain amount of preoperative testing that is kind of welcome and is okay for these higher risk cases. And we don't need to go through this table in greater detail, but as the title suggests, for those patients who are higher risk, so above ASA class 2, 3 or above, like, yes, it may through tests for a number of reasons, but it still shouldn't be like a universal test, like everyone who's an ASA class 3 gets an EKG, or everyone who's an ASA class 3 gets a CBC. So it's really still trying to say targeted and use evidence to drive who's receiving which test. And even this table was put together based on a lot of review of national information and society guidelines that suggest what types of clinical indications and risk warrant a test versus those that don't. We also, speaking of recommendations, looked into our EHR system and tried to modify testing recommendations that were essentially recommending low value tests. So on the left here are old recommendations. This is an example of a low risk lumpectomy case. And you can see it's kind of listing under orders needed here, that an echo is needed, an EKG is needed, an EKG stress test is needed. And really when we look at a case like this, and we look at the guidelines that our team put together collaboratively, like none of these are indicated. So we were able to go and work with our local HIT team and really change that EHR recommendation so that these low value tests are not being recommended for order, which is another thing that was suggested to by our input and collaboration with stakeholders. And so that's a quick summary of our resources. There's more that we can go into if people are interested, and some people may have seen this. We have a website with more information on preoperative testing, really trying to provide a little bit more robust detail in terms of the evidence and guidelines that kind of back up these tools and resources. But that's a summary of the resources and strategies that we put together, which brings us into the next phase in the process, which is kickoff engagement with targeted clinicians. And so this circles back to both finding a champion as well as gathering more focused data at request of those champions. So it's really, again, using the division chiefs of the 2 surgery units who perform these 3 surgeries and asking them to go to their groups and present to their surgeons and say, this is an approach that we want our division to take on, and this is an approach that I support of really, again, right sizing, reducing these low value tests for our group, and really using their kind of, reputation and clout as division leads to spread that information to their surgical teams. Similarly with anesthesia, working with the outpatient lead in anesthesia at Michigan Medicine, to work with multiple anesthesiologists to say, here is our approach and I'm comfortable with this and this is evidence-based, and kind of getting everyone on the same page through our champions. We also work with the preoperative clinic, which Michigan Medicine has with most surgical patients go through, and they were great partners and they actually worked kind of hand in hand with anesthesia. Anesthesia did some training with their whole team to help them better understand and clarify some things around that ASA class risk assessment. Because the way that our intervention worked, the PAs were actually doing the initial look and doing some test ordering based on assessing patients for ASA class. The intention was not that they would be perfect at that, but that they would be pretty good and could use that as a general guideline for whether or not they would order certain tests. So, as you can hopefully see here visually, the connection of these key champions allowed us to spread our message and spread these resources to numerous clinicians, not just through MPrOVE, but really through this collaboration with the key champions. And now I'll kind of wrap up with the end goal here, right? When we thought about the roadmap and how do we get started and how we end at actually reducing this low value preoperative testing. Has this approach been effective in reducing low value testing over the past year or so? And the overall answer is definitely a yes. We still have plenty of room for improvement. But when we go back to looking at the pre-period data of rates of inappropriate testing, like for these specific test mentions here, you can see that all of them have decreased. When we look at initial post-period data, we're still actually collecting some more, but we do see a decrease. We also obviously still see that a number of inappropriate or low value tests are continuing to be ordered. So I think there's still, plenty of room for improvement here. But this is probably a a little bit better way to look at, an easier way to understand. And it really goes back to what I talked about in the introduction and some of the background slides. If we look at the pre-intervention period, just see a lot of variation, not a lot of consistency in the proportion of unnecessary tests that are being ordered or the percentage of patients who are receiving an unnecessary test. And you can see after the implementation of the strategies I talked about, you do see a reduction in the proportion of unnecessary tests, but you also see some more consistency, which again goes along with that stakeholder engagement and kind of getting everyone on the same page and in agreement with the approaches that are there. So I'm happy to kind of talk through these results and data in any more detail, but just to kind of wrap up with our roadmap here. So this is kind of where we started at, again, going through these steps again that we did. So available baseline data, finding a champion or a lot of champions, and then the steps in the middle here are really like working with stakeholders to better understand why they're doing what they're doing and understanding the problem and like what types of interventions might change behavior, then developing resources, and then putting those out again through those kind of champion connections and those social connections with targeted clinicians. I do want to point out too that the available baseline data really is largely available through those MVC reports, which are just a fantastic resource. So in terms of at least a baseline look, it's not necessarily something that you have to figure out on your own. Similarly with the resources, decision aids, things like that, like those are available and can certainly connect you to those if you're not already. So those are a couple things that are, you know, largely steps in the process that you might have to do a little bit of tweaking on, maybe adjust to your local site. But those resources are largely there. I think the biggest piece kind of listed in the to-do icons here is that stakeholder engagement, finding champions, which is never easy, you know, champions who can spend a little time dedicated to the issue. And really just taking the time to talk through with them, what are the issues, what are the reasons that they might be ordering tests or, you know, slightly misreading guidelines or ordering something that they, again, their value is to increase safety, but may not be increasing safety at all. So just to mention that, you know, this was kind of our pathway, which again, doesn't have to be all of your pathways. But if you are interested, you know, some of these resources are available for sharing. And then just to kind of wrap up here on lessons learned from our work, goes back to the prior slide, again, kind of engage clinicians and physician champions as much as possible, as much as you can. They're kind of key for understanding the problem and also disseminating it through a large number of staff. Be flexible with the guidelines. I know I walked through these somewhat briefly, and I mentioned that we assess patient risk through ASA class. But I don't think there's any necessarily like hard and fast rules where you must use this resource or this decision tree. I think work with the clinicians you engage to kind of adjust that as something that works for your local site. The more critical piece is just getting to the place where you have guidelines that are agreed upon by different stakeholder groups that are actually ordering tests. Again, for us, those were surgery, anesthesia in the preoperative clinic. For other sites, those may include PCPs or other groups. But I think just having guidelines that are generally agreeable to different groups ordering tests is really the most critical piece. And then lastly, as I was hopefully able to display today, you know, try to share as much data and information as you can about throughout the process. I think in our experience, clinicians are open to seeing it and reacting to it and learning from it. Especially if you can, you know, gather data again that then links back to those primary values of clinicians of wanting to follow evidence-based medicine and really valuing the safety of their patients. So I will wrap up there and we can move into kind of some questions and comments from the group.
Wonderful. Thank you so much, Tony. That was a really informative presentation. Does anyone have any questions for Tony?
I have one I'd like to kick off with. It's kind of a two-parter. I wondered
Sure.
if you could talk a little bit more about if you know kind of what strategies or channels the surgery champions like Leslie and the anesthesiology person, and how they kind of filtered that message back to their peers within their departments. And then kind of the secondary question is, do you know if there ended up being any kind of spillover into other departments or types of surgeries, intentional or not?
I think those are two great questions. For the first one, we largely just use group meetings that were kind of led by those division chiefs or leaders. So like with minimally invasive surgery, actually Val from our team, who has just joined, hello Val, presented a little bit of information on our project and the resource we have available, but then our surgical champion, Dr. Obeid, was really the one to say, this is, I support this. I want everyone else to come along. Let's talk about this, and have a conversation at that meeting, and then subsequently to kind of like drive the message home. He also, just to use him as a good example of a champion, again, kind of requested that we share some of that background chart review data. He also like periodically kind of, after we had done that initial kickoff meeting and some follow-up, had asked for more information about, what the preoperative clinic PAs were doing, if there were any updates on, different pieces of data, things like that. So primarily through like a meeting and then some kind of like softer like email follow-up, if that makes sense. Similarly so that was kind of on the surgery side. And then similarly like with the preoperative clinic, we did a presentation to their all staff meeting, actually had, again, like anesthesia, Bernie Zhang, attend and present and kind of assure them that, anesthesia was supporting this. But really, I think like taking the time to talk through all of these concepts and let people ask questions, and then like adjusting the resources accordingly has been critical. And then the second piece, in terms of assessing any spillover to other conditions, that's not something that we have been able to get to yet. I think there's kind of two pieces there. One is, one is like assessing spillover from this more targeted intervention to 3 procedures. Two is like interest in expanding the same approach to more low risk procedures, which we've got a lot of interest on, and we do hope to do at some point in 2024. So sorry to not have a great answer there. Something we just haven't got to yet, but we'll certainly kind of be examining and looking at in the months to come.
Great, thanks so much. It looks like Susanna might have a question, if you want to bring yourself off mute. Susanna Fortney, are you still with us?
Yes, can you hear me now?
Yes.
Oh, sorry about that.
Mhm.
I had a question about primary care. We often see patients that had lab work ordered by primary care, but it was appropriately ordered for diagnostic purposes or related to medications. And then the patient is referred to general surgery and has a low-risk surgical procedure all within 30 days of that lab work. And the intent of that lab work was not for pre-op surgery. It was appropriately ordered, but it's still affecting our numbers as far as having that ordered. So I just wondered, when I met with primary care, there really wasn't an answer or a workaround that we could come up with, because it was appropriately ordered, and with our surgeries being able to be scheduled in less than 30 days. I mean, that's a plus thing for the patient, and we don't want to say
Right.
we're going to need to wait 30 days. So is there a workaround? What recommendations do you have for that? Thank you.
Yeah, I think that's a great question. I don't think I have a great answer for you. I mean, it does sound like in your situation that actually doing that probably reduces patient burden and is more efficient. Part of the reason I can't answer is, again, we primarily worked with the preoperative clinic, who really handles the vast majority of pre-op testing decisions at Michigan Medicine. But I understand the question in the context of the MVC report. I wonder if anyone from MVC has any thoughts on that. I wouldn't expect a great answer. I think it is just an issue of trying to collect similar data across a large group of hospitals. But anyone from MVC have anything they wanted to add on that question?
No, and I appreciate that question. I think we've heard some, similar things before, and that kind of approach we have to take with the claims because we can't tell what the purpose of the test was. That's definitely a limitation. But I would say that the fact that you kind of have those connections and your own data, and that those tests are appropriate, is that kind of piece that Tony mentioned about, like, our kind of reports are the base, we're the canary in the coal mine, sort of, and then the more nuanced data that comes from your hospital or your EMR or whatever is the real deal. That's the stuff that's going to tell you, like, real rates. And I mean, it doesn't help with kind of being able to compare MVC reports to your current reports, but I think when you if you are catching cases that are kind of unnecessary, you will over time see those sort of delayed MVC reports kind of go down. Those rates will go down. But yeah, fair point. I don't know if you have anything else to add, Christy, but
No, nothing else to add. Thanks for that input.
There was a question in the chat on the TNS and laparoscopic procedures. I think the risk there is really related to just the blood loss, but I can also admit that I am not a clinical person who put the guidelines together. Again, these are based on a lot of nationally accepted guidelines and societies, as well as some local clinician input. So I don't have a great answer for you there. I will say that I think if you're considering expanding or kind of like using these resources as a starting point, like certainly something that could be discussed with local providers, and again, like kind of adjusted or made flexible kind of as needed, whether it's viewed to be valuable to do a TNS or not. If that doesn't answer your question, feel free to join in. Sorry if that's not a perfect answer.
Wonderful, thank you. Does anyone have any other questions for Tony or Val, who just joined us?
I can just add, and I know I kind of started here with some of the background slides, but just that, as hopefully all of you know, since there's 40 people on this work group call, but MVC has been really great to kind of partner with and work with, and I think, as was mentioned, like really provide that really good baseline data that's consistent to hospitals throughout the state. And then this has been a bit of a kind of a supplement to that, getting into a little bit more details on intervention and resources. So, just to give a shout out to MVC as a really great partner in this, again, like truly going back 4 years or so.
Wonderful, thank you. And as Jana mentioned in the chat, MVC is expecting to send some refreshed preoperative testing reports in November. So stay tuned for those. And thank you for your partnership, Tony and Val. Wonderful. So I think we could go ahead and conclude the work group if we don't have any other questions today. I am going to go ahead and paste the work group survey in the chat for everyone's reference. If you could complete this, that would be greatly appreciated. And then I'm just going to go ahead and bring up my screen again to conclude the work group with some upcoming events for MVC. Thank you again for presenting, Tony.
Happy to be here. Thanks, everybody.
Wonderful. So on the slide here, you can see some upcoming events for MVC. Our next work group will be a diabetes work group, and that will be on November 2nd from 1 to 2 p.m. And that is going to feature Gina Shutter of Holland PHO. Next, in recognition of National Rural Health Day on November 16th, we have a Health and Action work group on November 15th from 11 to 12 p.m. And that is going to feature Stephanie Pins of My Michigan. And then lastly, our first work group for December will be a cardiac rehab work group, and that is going to feature MVC's project manager, Janice Stewart. So we hope to see you at some of these upcoming events. Thank you again for being here. Thank you, MPrOVE, for presenting. As a reminder, today's work group slides and recording will be shared following the work group. If you have any questions at all, please reach out to us. Again, if you could complete that survey that was posted in the chat, it also will be emailed as well. That would be greatly appreciated. Thank you again for your support of MVC, and we look forward to seeing you at future events. Thanks so much. Have a great day, everyone.